Welcome, everyone, and thank you for being here. I am Paola Gamboa, Education and Digital Manager of the Graduate School One Health Emerging Infectious Diseases. And the Graduate School One Health Emerging Infectious Diseases started in 2023 a transdisciplinary program for master and PhD students, including biology of emerging pathogens, epidemiology, veterinary sciences, ecology, evolutionary biology, and social anthropology. Committed to its goal of preparing the greatest number for the challenges ahead, the graduate school is launching today a series of webinars presenting each year subjects of global importance proposed by researchers based in France and around the world. This webinar series aims to raise awareness about emerging infectious and deepen our understanding of what drives their evolution, pathogen mutations, host and vector changes, and new strain emergence. We will also explore and identify actionable strategies for collective response at regional, local, national, or international levels, including innovative methodologies, ongoing studies, and groundbreaking results. This content targets master and PhD students, early career and senior researchers, and professionals across health, veterinary, and pharmaceutical fields. For its inaugural edition in this 2025-2026 academic year, the first theme is One Health Research in French Amazonia, chaired by Professor Loïc Eppelboin. Today, October 29, 2025, we welcome Professor Maylis Douine. In November 19, 2025, we will welcome Professor Hatem Khalel. In December 17, 2025, we will welcome Professor Roxane Chaube. And in January 28, 2026, we will welcome Professor Benoit Detoisy. The four sessions take place at 12:30 p.m. Paris local time. Concerning the webinar structure, the invited speaker will present the theme for about 40 minutes, followed by questions and answer sessions. The audience can share the questions in the chat every time during the talk or ask them directly during the discussion period. Without further delay, I'm delighted to introduce Professor Loïc Eppelboin, a leading researcher in infectiology and epidemiology of infectious and tropical diseases. He is a full professor and hospital practitioner in the Infection and Tropical Unit at Cayenne Hospital, Centre André Rosemont, in the French Guiana Department. Professor Eppelboin, the floor is yours.
Thank you so much, Paola. Thanks to all to be there today. This is something very new for me, and I'm very honored to be with Paola and also Professor Solène Carnist to start this really special webinar of One Health Research in French Amazonia. And we've got the great opportunity to guest for the first time Professor Maylis Douine, which is a friend I know for a very long time. And the talk she will present today is very interesting because this is an amazing subject first, and secondly, this is also the pathway for a young doctor who arrived like 12 years ago in French Guyana with an idea of what she wanted to do, and she started just from idea. I want to travel, to work with gold miners, malaria. This is a hole in all the research in French Guyana, and today she's one of the most recognized researchers on the subject and on malaria in general. So Maylis Douine is professor in French Guyana. We are a very young university hospital. We've been created in July 2025. And she's researcher in the West Indies and French Guyana Investigation Center. She's got PhD in health science. She's got what we call HDR, or ability to supervise research. And she's working on vulnerable and hard-to-reach population for 10 years now. And she started from quite simple stuff She's implementing strategies, health public strategies again to struggle malaria all around the world. But the best thing to do is to let her talk and present all her works and all she's doing, and you'll see it's very passionating. Maylis, that's your turn. À ton tour.
Thank you, Loïc, for this presentation. So, thank you today. Good morning or good afternoon, depending of where you are. So, as Loïc presented me, I'm Maylis Douine, so I work in French Guyana. And as I'm the first one to talk to this webinar, I will introduce a little bit our situation in French Guyana. So we work in a research department here in Cayenne Hospital, University Cayenne Hospital, and you can see we have a new building, very, very nice. So if you want to come for investigation, for training or everything, you are more than welcome. We work in different topics, disease, but also access to care, nutrition, food insecurity, or chronic disease. And me, I work on malaria for the last 12 or 13 years now. So French Guyana is in South America, so it's not an island. It's between Suriname and Brazil, covered by rainforest. It's quite small, 300,000 inhabitants only, but very young. Half of the population is below 25 years. And most of the population live on the littoral, Cayenne, Kourou, and Saint-Laurent-du-Maroni, where there are 3 hospitals, and all the rest of the territory is covered by rainforest and with small health centers. We are quite famous because we are a formal penal colony, so yeah, it's 100 of years. But we also hold the European Space Center in Kourou since 1964. And the biodiversity is really amazing. So if you want to come, really, I'm sure you will enjoy the place. And my colleagues after will talk about bats with rabies. We'll talk about snakes. We'll talk about tattoos. But really, the biodiversity is amazing and so many things to see and to enjoy. And another particularity is the soil. The soil is very rich in gold. So the rush gold started in the mid-19th century until now. There is still a lot of gold miners. Some are legal companies. Legal companies extract about 2 gold each year, but we also have the problem of illegal gold mining with people coming mainly from Brazil, entering the French territory either directly from Brazil to French Guyana through the river, the Oyapock River, which is the border, or going first to Paramaribo in Suriname by plane or by boat, and then they go to the Maroni River, which is the border with Suriname, and they enter the French territory as well. We estimate that currently it's 10,000 of illegal gold miners, and they extract 10 tons of gold each year, so 10 times higher the legal extraction. There are more than 700 of informal sites, very remote in the forest. So when I started to raise the question of malaria, I saw in 2013 that there were 1,000 of malaria cases per year. Most of them were falciparum, and the place of infection was from the forest. So it's quite vague, mainly because it's supposed to be an uninhabited forest. So I was wondering, what is these cases from the forest? I started to investigate. And I decided to, and I understand that there are these people coming for illegal mining, and I decided to implement a cross-sectional survey, so just a descriptive survey to understand the situation. So it was quite basic, going to the logistical workplace where the gold miners are going to sell the gold or to buy supplies or just to have some rest. And there we include the people who are just coming from the French Guiana territory. And we do a questionnaire, a blood sample to evaluate the malaria prevalence by PCR, and the questionnaire to ask questions about CAP, so knowledge, attitude, and practices about malaria. So we were a team of 3 people, 1 nurse, 1 facilitator, so like a health mediator, someone who knows Portuguese very well, because as I told you, they are from Brazil, and a medical doctor to perform a medical exam. And the results were very bad. We included 421 people during 6 months, and the prevalence was 22% of positive in PCR. It was really high. We didn't expect so high prevalence. Most of them were asymptomatics, meaning that they had acquired partial immunity, allowing them to carry parasite without any symptoms. 60% were the species were falciparum. Maybe you know the different kind of species of malaria. There are falciparum, vivax, and other. And in French Guiana, it's mainly falciparum and vivax. The falciparum is the one with the most lethal and morbidity associated. In the questionnaire, we also saw that these people are very mobile. They move a lot within the different mining in the French territory, but also to Brazil to go back to see their family, or going to Suriname where they are friends or wanted to have some rest. And when we ask them, what did you do last time you experienced malaria symptoms? More than half of them use self-medication. So they buy medication on the black market. And the main drug they buy is Artecon. Artecon is containing dihydroartemisinin, so an artemisinin derivative. So it raised the concern of the emergence of falciparum resistance, and artemisinin is the best treatment until now. So if there are emergence of resistance, it's really complicated then to treat the people. And secondly, the high mobility hampers the risk of propagation of malaria in the region, because they are asymptomatic, so they even don't know that they are sick. Why these coal miners are so exposed to malaria? Many reasons. First, the Anopheles mosquitoes, so the responsible for transmission, is mainly from the forest, and deforestation that they do for gold mining is increasing breeding sites. So there are a lot of mosquitoes in the forest. And secondly, they are very far from the health system. As I told you, sometimes it's 3, 4, 5 days by foot to go to the health system. So when they get sick, they don't go. So they can carry Plasmodium a longer time than people who get sick and go to the health system and start a treatment quite quickly. WHO recommend to start the treatment within the 48 hours after the onset of the symptoms to decrease transmission and to avoid morbid mortality. So WHO wrote a lot of guidelines to control and to eliminate malaria. So we know what we have to do. But the problem is that in the context of illegal miners in French Guiana, it's really complicated. First, there are police operations trying to control, to fight illegal miners. So it's complicated to be in the middle of police operation and the gold miners. Secondly, it's really remote. How to access these people who are so far away, and it's quite dangerous and even logistically really complicated to reach. And in France, someone who is not a medical doctor cannot do a diagnostic test or give a treatment to someone else. It would be illegal practice of medicine. And we lack medical resources in French Guiana, even in hospitals. So it's impossible to send medical doctors in the mining sites. So we have to innovate, to create something new and adapt it to our territory and our regulation. We decided to implement a new strategy based on self-diagnosis and self-treatment. We call it MalaKit, Mala for malaria, and it's a kit for self-diagnosis and self-treatment. We implemented this intervention in countries, Suriname and Brazil, and including not only researchers, but also civil society and health institutions. This project, we wanted that it could be sustainable if the research parts show it will be very efficient. So that here, all the partners on the project are very numerous. And we implemented this project within a research framework, meaning that we evaluate not only the effectiveness, but also the intervention, how we implemented the project. It's working, and not only is it working. That's the kit. So it's a plastic pouch, waterproof, easy to carry, not so big. I have one here. I don't know if you can see. So just a small plastic pouch with one diagnostic pouch with 3 RDTs. So it's single packaging and retractable lancets for pricking the fingers, so to avoid risk for contamination, blood contamination. And the other pouch is for the treatment, with a complete treatment with artemether lumefantrine and paracetamol, pain, and so on. I won't go into details of the headache or administrative setup. It was really complicated and challenging for regulatory process in the 3 different countries, 3 different ethics committee, data security, finding funders. So finally, for the funds, it comes mainly from European funds, but also a little bit from WHO and also from the Ministry of Health from Brazil and Suriname. We speak 3 different languages. There are no roads to join Brazil or Suriname. Just 1 flight per week, very complicated. Just an example for the logistical challenges. Here are all the different components from the kits. And you can see that some of them are coming from France, that from US, that from Suriname and Brazil. And all the question of custom to send different components and medical components, it was really crazy. And at the end, 1 kit, it's about 8 USD. Here are the complexity of the data collection system implemented by Yann Lambert, who was a PhD student in this project. Because of geographic isolation, internet access is really poor. There are problems with the electricity supply and the data protection, because France is Europe, so it's a RGPD regulation, so with a lot of difficulties to really secure all the data. So at the end, that's a shame for data collection. I won't go into details either, but you can see it's very, very complex. Now a word about the facilitators. They are really key people in this project. They are, we call them facilitators, we also call them health mediator. They are people who know very well the population targeted, so illegal minors working in French Guyana. So they speak Portuguese because they are from Brazil. And they were in distribution sites in the different borders. You can see here in Albina, Grand Santi, Ronaldo, in all the different places, we are fixed points for distribution of the kits. So all day they go do outreach to discuss with the gold miners, to explain the project, to talk about malaria, and to train for kit utilization. So a gold miner can receive a kit on this distribution site at the 2 border. He go with the kit in the forest where he's planning to work. The day he has any malaria symptoms, he can do a diagnostic test. And if the test is positive, he can take the treatment, which is in the kit. Of course, we explain them that it's always better to go to the health system. The kit is not to replace the health system. It's just in case they don't have access in the 48 hours after the beginning of the symptoms, they can start the treatment. We also explain the severe symptoms in the cases where they really need to go very urgently to the health system. And when they go back to distribution sites for rest or, as I said, for buying things, supplies and so on, they can have a refill of the kit or a replacement of the kit on a distribution site. There is a training, an important training before receiving a kit. So we created different information and education tools, videos, drawings, even a phone app with all the information required. And the people have to perform RDT in front of the health mediator to show that they really are able to do the RDT and to interpret the results. And then they can have the kit and a mosquito net. We designed the kit within a quasi-experimental design. The high mobility across mining sites prevented a stable comparison. Therefore, we adopt a before-after design to assess the changes within this population over time. So I presented you a survey on the Surinamese border in 2015. We do the same in 2018 at the Brazilian border to have the pre-evaluation situation. Then we implemented the distribution of the kits for 2 years. And by the end of 2019, we did another post-intervention surveys. I already presented you the data collection, first visit, follow-up visit. So now the post cross-sectional survey. We also implemented a way to report safety data through the network of the health system and the hospital. We implemented qualitative survey with a collaboration with University of Montreal to have information about the acceptability of the project, how the gold miner perceives the project, in a qualitative way and what they would like to improve in this project and implementation data to really understand what we have done. The main objective is to change the behavior. So to increase the use of adapted treatment with a certified ACT, not drug from the black market, after a positive diagnostic for malaria. And the secondary objectives are to improve knowledge and practices, decrease malaria prevalence, and evaluating the safety of the intervention. The results. So in this 2 years intervention, we distributed 4,700 kits to 3,700 participants because one participant can receive several kits. And according to the follow-up visit, 70% used the kit correctly. So we were quite happy with that. Doing a capture analysis, we estimate that we have included 1/3 of the study population, so gold miners from French Guiana, who receive at least 1 kit. Regarding safety and ethics, the DSMB, so the Data Safety Monitoring Board, it was an independent board looking at all our data to evaluate if it was not unsafe for the participants. It did not raise any concern. The black market circulation was quite low. It was one of our concerns as well to see how many people will sell the kit in the forest. So there were some, but not so much, because people knew quite soon. So I think it decreased the price of the kit if you can get it for free. And no specific ethics monitoring concern with a very good consent record. So the impact on behavior and species. So the first line in red is our main objective, how to increase testing before using certified ACT. And we have a significant increase with the odds ratio of 1.8 of appropriate behavior. Regarding prevalence of malaria, so just across the pre and post-intervention surveys, in green, it's in Suriname, and you can see it decreased more than in Brazil, in yellow, because it was not also the same period of time. The cross-sectional survey in Brazil was in 2018, but it was significant, from 22 in Suriname to 5% at this border. And in the same time, the proportion of falciparum decreased from almost 60% to 15%, and even 0 on the Brazilian border. So the worst one. Jan Lambert still, for his PhD, tried to model the impact on malachite on the incidence of malaria transmission. He did 2 different models. The first one is this one, interrupted. So here, this line is showing you what we observed with the use of malachite, the implementation of malachite, and the small line here is the counterfactual scenario, meaning what would happen if nothing was implemented. And it shows that it prevents an estimated 43% of the cases of malaria imported from French Guiana to Brazil and Suriname during the period study. Then he did another study, modeling, SIS, which has been published in the Lancet just 2 or 3 months ago, differentiating falciparum and Vivax. So falciparum is the first one and Vivax the second one. And he estimates kind of number of adverse cases, 1,000 for PF and 2,002 for PV. In the same time, here are the data from the surveillance system in French Guiana. Malaria is still continuing to decrease, but so malachite was 2018 to 2020, and we experiment an outbreak of malaria in 2023 and 2024. So elimination is not really here. So for this malachite strategy, of course, we have a lot of limitations. It's not experimental design. We don't have so much number of kits used reported. There are different time periods for the cross-sectional surveys. It's based on declaration, so we can have a bias on memory bias. They can have interference. If Jan included seasonality and also police operation in his model, we can still have other interference we even don't know. But we also know that we have benefits. We increase the access to diagnosis and treatment for a very hard to reach population, very vulnerable population. The kit use is good. I don't know if you have any idea about the adherence of treatment for antibiotics, but in France, for pneumonia, I think I read a paper, it was about 30%. So it's great. We probably have an impact on the disease according to these two models, and the intervention was safe. So given these good results, we thought to advocate for integrating this strategy as a new tool. It's not for replacing other strategies, but it could be a new tool. We believe Malakit could be useful for specific population or context. That's why we participate to several conferences to present our results, to discuss with people. We produced a documentary film, which was selected for the Innovation Prize in WHO Health for All Film Festival. And we participated as well in another documentary with Juliette Binoche, here in the picture. We designed a website with all the information. You can have a look on it. It's in English, Portuguese, and French. We explain all we have done, and we also record all our publications. Unfortunately, Josh Clooney was not available for us. So back to research on population health intervention. First, describing the situation. Secondly, to intervene. So now, what is the next step? It's a question of sustainability, transferring, and to continue to intervene in our territory as well. Regarding sustainability and transferring, we are very happy now because the Malakit strategy has been integrated into the regional national program here in French Guiana. So now the activities, the distribution of the kits are continuing outside the research scope through two teams, one from the Red Cross and one from the health centers. Unfortunately, due to the team from Red Cross will stop soon, but it's still continuing. We are happy with that. In Suriname, they have integrated as well the Malakit intervention since the end of the research part, so since 2020. It has been integrated in that program, the national program, not only at the border with French Guiana, but also at the border with Guyana. So they have translated the kit in Chinese, Dutch, the language in Suriname, English, Spanish, so it's quite fun. And Suriname is now officially malaria since June 2025. Malakit is also is considered in other countries, in Brazil. Two pilots should have started this year, but it's postponed to next year due to political reason. Colombia is also considering the project for gold miners at the border with Venezuela. And two pilots are really ongoing by now. One in Senegal, here in the Kédougou region. It's for gold miners coming from Guinea or Mali and going for illegal mining as well in this region. And the other one is in Tripura. Tripura is a state of India at the border with Bangladesh. It's for slash and burn cultivators. So it's another kind of jungle. It's more hilly jungle. We were there with my colleague in May. So completely different context, but it's the same problem of access to the health system. We have published an article to explain the different steps for transferring the process, and like a guide for the people who would like to try this strategy in other contexts, and how we did and what kind of question we have to ask. And here is Carlotta Carboni. She's doing her PhD on the transferability of Malakit. And here, in our context, as I showed you, now we don't have so much falciparum, but we have the problem with Vivax. The problem with Vivax is that it can stay in the liver for weeks or months and causing relapses because of hypnozoites. So like sleeping parasites in the liver. So with Alissana in the picture, we set up a new project called Curema, trying to target the P-Vivax. So we continue the distribution of the Malakit, but we add a radical cure with chloroquine and promecan or tafenoquine for eliminating the parasite in the liver. This project, this idea is to treat the potential carriers of P virus with epidemiological criteria. So people who have malaria attack during the last year and the last year, or okay, and to use the new technology available, because now tafenoquine is a single dose treatment compared to primaquine, which is a 7 or 14 days treatment course, and to use a GSPD point of care testing, which is very useful because we need to check if the people are deficient for GSPD before to give 8-aminoquinolane. And we are going to follow up through phone calls, application to check for side events. So here are some pictures of this project to explain the people how to take the treatment, to explain the malaria incubada, so the malaria we cannot see and can stay in the liver. So we just finished this project in April 2025. So I won't spoil, I won't give you any result by now. You will have to wait a little bit. We have many also collaboration with other teams to do different kind of work related to malachite or curema. With Harvard, we worked on genotyping the strains, for example, with Dan Nifty, to see if all the strains of malaria we regarded last 10 years in all these projects, how much they are related together, to know if it's always reintroduction of new parasites or it's always the same parasite circulating in the French Guiana territory. We do also modeling for cost effectiveness, so to evaluate the cost and the benefit of the strategy. We work with the Institute of Tropical Medicine in Antwerp, Belgium, with Twan in Guyane for qualitative surveys. We did the same for malachite with the University of Montreal, but now it's a more extensive qualitative survey evaluating not only the acceptability, but also the factor for the sustainability and all the external factors who impact the effectiveness of a project. We worked on practicability of RDTs, how to advocate for the use of RDTs as self-testing. We are working also for an IA, artificial intelligence, AI, sorry, for interpreting automatically the RDT results. So to have like a control, and this IA would be able to send the result directly to the surveillance system. And we also continue modeling the different patches. For example, in French Guiana, we have this population of coal miners, but we also have the population of military who intervene for police operation, who are really in close contact with the coal miners. So they also have the problem of malaria and with local population, and to evaluate how the malaria is transmitted to these different 3 patches. And I presented you all our work on malaria, but these people are looking for gold, and they are finding so many other health problems. They are exposed to biodiversity, so with the question of zoonosis, to heavy metal intoxication, STIs because of commercial sex, violence, really a lot of things. So when we do these cross-sectional surveys, we do not only look at malaria, but we ask a lot of questions and we take blood samples for other diseases. Here are just some information, some results, but you can find on PubMed. For example, we ask them for the bites, and so many people are bites, 60% during the previous year. And last year in 2024, 3 coal miners died because of rabies. So it's a really huge problem for this population. They are exposed to mercury, so of course it's very bad for the population downstream and for the environment, of course. But themselves, they are also intoxicated with mercury. They have problem of food insecurity, because when police is coming for fighting gold mining, they are burning everything. They burn the oil, they burn even the food, they burn the hammock, they burn everything. And this population, these people stay in the forest without nothing, and they really have a problem of food insecurity. They are exposed to different kinds of zoonosis, mainly leishmaniasis. It's a main problem for them. They are very exposed to leishmaniasis, and there is a black market of glucanthine, pentacarinates. It's crazy, and it's a very important problem. They're quite well vaccinated for yellow fever. They don't have so much problem for Q fever, but they are also exposed to leptospirosis. 30% of them were seropositive in leptospirosis, and there are antibodies who stay for 18 months, so meaning that there is transmission of leptospirosis in the gold mines. There is exposition to violence and to STIs, mainly syphilis. We don't raise any concern with HIV, but with syphilis, it seems to be a problem. So illegal gold mining severely impacts collective health and environment for sure. But this hardworking condition also impacts their own health, their individual health. And I think it's important to raise the question. Miners are just the first link in a long chain. Who is buying the gold at the end of this chain? Most gold ends up as monetary reserve or jewelry, and only a small part goes to industry. So let's keep the big pictures in mind and avoid stigmatizing this population. For the francophone, Coluche disait, il suffirait que les gens ne l'achètent pas pour que ça ne se vende pas. And gold is, it's only 5% for industry. All the rest is monetary reserve or jewelry. These projects involve so many people. I won't risk to name anyone, but you can see in this year quite a lot of people who have participated to all this project. And I really thank the facilitators, really key people in this kind of intervention. Here are some of the references, but as I told you, in our website, you can find all of them on PubMed. Here are all the partners. Again, the websites, if you have more information, and my email. So feel free to contact me if you have any question. Thank you.
Thank you so much, Maylis, for this amazing talk. I've heard it a lot of time, but each time there is some new, actuality, some outbreaks, many things, new projects, new collaborations, new countries with whom you are working with. I didn't remember Colombia. I knew about Senegal and India, but Colombia, I was not sure about that. And it's becoming from green on your map to yellow and then violet. That means that it's going always like further. Are there any questions in the participants? Feel free to ask any questions in English, or if some French people are not secure in English, I think that Maylis will understand your French. She'll try to. I think that Professor Kernes has got a question.
Just to start the discussion. Well, Maylis, thank you so much for this fantastic talk. Really, I was really impressed by your results. Very surprised by the compliance to the protocol. In particular, in a very specific population, and I wouldn't expect such a success, such an achievement. So congratulations for that. And so my question is really about that. How do you explain why it has worked so well? I mean, do you think it's because it's a specific population and that they were very eager to have access to medication and they are not really used to? Do you think it's the quality of the implementation of the intervention? And do you think it's precisely because there was no doctor between them and the medication that finally it worked well? So yeah, what is your interpretation for that? And do you know if there are similar programs in other contexts with different results? And what could you explain that?
Okay, thank you. So yeah, malaria is really a problem for gold miners. So as it's a problem for them, they really accept the training. We design all the education tools in the training with the population. So we design the drawings, the videos, every steps are designed with the community. So to really adapt the information to what they know and to their representation of the disease. And it's free. So that's also something very important for them. So I think, and the facilitators as well are really key people. People who can train and knowing very well the population. And I think it's a medical doctor who's doing the training directly to the gold miners. He won't have worked so well. It's because really the facilitators can adapt the messages, the information, the training to the specific population. And I'm really convinced that any people, even with low education, half of the gold miners population has a primary or non-education level. So yeah, 50% of them cannot read, cannot write. And they are able to perform RDT and to take a treatment correctly if we explain very easily the concept to them. So I think it can be the same for other population with the specific education tools created with the community to really adapt to their knowledge and their representation. And for other kind of context where the strategy has been used, not really. There were some tests with travelers or for oil companies in I don't know, offshore like
Platforms, yeah,
offshore platforms trying to do that kind of things, but it was in a small population, like 30-40 people, and it's absolutely not the same kind of education level, so it's not comparable.
Thank you. And thank you again for this fantastic talk. I don't know if there are other questions in the audience. Yeah, I think so.
Camilla Roth, I think you've got a question from Munich.
From Munich, yes. Hello, everyone. Thank you very much for the wonderful talk, abducting us into the Amazon forest. Since I'm interested in the performance of the rapid diagnostic test, because this was the mainstay of diagnosis, obviously, and had to be. So are you using histidine-rich protein 2 or 3 based tests? Did you have any idea if there are mutations in the HRP2 or 3 gene in the region? And since it's often said that the rapid diagnostic tests are not so useful for diagnosing non-falciparum malaria, I would also be interested to hear what your experience is in your Vivax project that you had.
Yeah, thank you for this question. So yeah, it's a really important question. During the Malakit project in 2018 to 2020, we used a test which was just PLD, or no differentiating any species, because we wanted to have the easiest one for the gold miners. Is it positive or negative? But we treat everyone with artemether lumefantrine. And during the second project, the Curema project, so first, this RDT was not produced anymore because the company used all the platform to do COVID tests, so they were not producing this test anymore. So we used another one with HRP2 and LDH as well, so PLDH and HRP2. We don't have any concern with the HRP2 deletion in French Guiana and either in Suriname and Brazil until now. So it's not a problem for us. And Pasteur Institute here in Cayenne is doing some surveillance for HRP2 deletion. So we are sure we don't have deletion. So it was not a problem. But we evaluate again the practicability of the RDT with the 3 bands and even the 4 bands, because the one we use in Brazil is 4 bands. And we can see that the people are really able to interpret. Is it positive or negative? We don't ask them to specify if it's falciparum Vivax. And in the new project, Curema project, so we continue to use these RDTs in the kits, so PLDH, HRP2. And for the people who come to the distribution site to receive a Mala kit, we ask them if they have a malaria attack during the previous year, even symptoms of malaria, even if they don't have a specific diagnosis. And we retreat them with chloroquine and primaquine or tafenoquine. So it's like a way to capture people who might have been under-diagnosed of Vivax in the forest as well.
Thank you very much.
Maylis, there is a question on the chat from GBCH63 something. My question is, since this malakit is an RDT-based test, isn't there a risk of false positive testing and unnecessary treatment, since RDTs can remain positive months post-infection and therefore do not necessarily reflect an active infection? It's
Yeah, the performance of the RDTs are known. We can have some positive tests, but it's quite few. And the antigen, HRP2 or LDH, are just staying in the blood for 1 week or 2 weeks. It's not for months. So we cannot have positive tests because of other things months after a malaria attack. But if you have symptoms of malaria, you do a RDT, you're supposed to be positive. But sometimes at the really beginning of the symptoms, your parasitemia is still quite low and you can have false negative. So we ask the people to redo a test after 24 hours if the first test was negative. So it's for the false negative. For the false positive, as I said, it's only 1 or 2 weeks after a first malaria attack. So
yeah, I do agree. My personal experience with these people with Vivax malaria is that even with symptoms, RDTs are the problem is false negative more than false positive when we compare with the PCR against RDTs. Any question in the rest of the assembly? There is another message in the chat. Hello from Lexi. Hello, great talk and very promising kit. Perhaps I misunderstood, but how did you get permissions to put ACT in the test, given how safe gold these drugs are for fear of resistance?
yeah, that was an important question we have discussed so much before the launching Malakit project. Are we doing something bad, worse than the pre-existing situation by giving so many drugs in the forest? But in the other side, they are already using artemisinin derivative in the forest with absolutely no control. So the ethics committee gives the permission to do the project and to see if it would be better to give ACT with a strong monitoring, a strong supervision, was better than letting the as it was, meaning a huge black market of ACT. We implemented the DAFTA Safety Monitoring Board also for that. So an external committee with 4 experts, malaria experts, who look at all our data 3 times a year, 4 times a year, I don't remember, during the entire project to really evaluate if what we were doing was better than doing nothing.
Anyone else?
Well, in my case, I have a question regarding the transferability of the Malakit tool, since the idea is using it, implementing it in several countries. How is the context take into account the geographical aspects, the socioeconomic aspects, or the cultural conditions? Because sometimes we know that people is reluctant to accept treatment, and how can we, for example, adapt it in the Colombian context, in the Guyana context, Brazil, and you mentioned also countries like India and other places around the world. How is this aspects? How are these aspects taken into account?
Yeah, it's really important. I think this question, so Malakit is useful for very specific patients who are not reached by the health system. If they can have access to the health system, it's always better. But if not, because they are very remote geographically or anything, Malakit could be helpful. And the approach have to be really bottom up. We have to design all the strategy with the community, doing focus group, discussing with them what are the representation of the disease, what are their problem with the disease, to present the idea of the kit. Will they be reluctant to use it? Is it adapted to what they want? The education tool, we have to create the strategy with the population. It's how we can have the acceptability of the population.
Thank you.
Anyone else? Well, Paola, maybe it's time to close this first webinar. What do you think about it?
Well, yes, I agree with you. I think that was really impressive, really interesting to see how the project has evolved and all the partners that are involved. I don't know if you would like to share again the website for the Malakit project, Maylis. I think it's www.malakitproject.org. I don't know if you want to share the link with the audience. And perfect, thank you. So if you are interested in getting more information about the project and also in contacting Professor Maylis Douine, you can do it. Thank you again for participating. We are really glad to have this first session with all of you, and we wait for you for the next session that will be next month with Professor Hatem Khalel. Thank you, Loic. Thank you, Maylis, and have a pleasant afternoon. Thank you, Solène. I don't know if you want to have some closing words, Solène?
Yeah, thank you so much for organizing these webinars. I think the replay of the talk will be available on the website of the graduate school as well.
Yes, you're right. We will share the recording on the website of the graduate school.
So let's meet up for the next webinar. And thank you again.
Thank you.
Thank you
everyone.
very much. Very, very interesting.
Bye-bye.
Bye-bye. Thank you so much to everyone.